So I want to start today by acknowledging the lands of the traditional owners that we're on. So greetings from Wathaurong country. I want to acknowledge the traditional owners past, present and emerging, and acknowledge that I'm sitting here on stolen land. I want to also acknowledge that I come from a pretty privileged position as a white woman, and I feel like all the stories I've heard about how hard our journeys are, I start to also imagine what it must be like when there's no health data on Indigenous people and their experience of pelvic pain and what that must look like for them. So I really hope that that space changes over the coming years. Sorry, I've got to admit people at the same time. At Endo Help, we try to create events where all feel included and seen. We're aware that slippages in language can cause hurt and triggers. So throughout today's presentation, our speakers have made an effort to be inclusive. There will be some gendered information throughout the presentation, which is because so much of the research is gendered, but all of the information is relevant to all people with endo and all sexual identities. If any of you have any issues with any of it afterwards, I always welcome any conversation. We're all really open to learning. We've got 3 speakers who've offered to give up some of their Sunday to meet with us all and answer your questions today. I'm so grateful we have passionate health professionals in our region who are really trying to make a difference for all pelvic pain warriors. So our first speaker is Rochelle Hamilton. She's a clinical sexologist who offers sex counselling to all who feel they may require assistance to understand, accept themselves as sexual beings and meet their sexual goals. Rochelle maintains a broad perspective within this area by being aware of and taking into consideration important variables that influence one's sexual being. These include one's biological, psychological, sociological, cultural, and historical influences. Rochelle practices with evidence-based treatments and comes from a non-judgmental framework. I'd like to also say, while Rochelle is presenting, please feel free to put questions in the chat or just ask directly. We'd love to hear your questions. Over to you, Rochelle.
Thank you. Now let's see. Oops, let me see if I can do this again. Okay. Now. Is that it, Kat? Can you see it?
Yeah, it's looking good.
Excellent. Okay. Welcome everyone, and thanks, Kat, for this opportunity to chat to people again about pelvic pain. And today I thought that I would really focus on the intimacy component and why, when we experience pelvic pain, why is it so far from how we can share intimacy as well, and that they don't need to be miles apart. I acknowledge that it is difficult, and I've certainly ridden this train with people before. So let me hope that I can offer some insight on how to gain and maintain intimacy still with pelvic pain, and give some opportunity to some people to also share that journey in a language that their partners can understand as well. So words that become all too familiar when we're suffering with pelvic pain, for whatever reason we might be suffering from pelvic pain. And these are the most common things we hear about: menstrual cycles, cramping, abdominal pelvic pain. We're told constantly from a young age of experiencing our first menstrual cycle, it's all normal, it's just your period. Then we progress into painful sex, painful periods, heavy periods, and we're not supported too well for a long, long time on how to manage that and what it means, when we should try and manage it, how, and to try and get some sort of clarity about a diagnosis of what the pelvic pain might be, whether it be associated with your period itself or whether it be associated on the journey of the menstrual cycle itself. It does impact us at school, our study, our work and our relationships, whether or not they be social or whether or not they be intimate. And then we go into the next journey of our lives for a lot of us about the fertility aspect and how that impacts us as well. Period pain is more than period pain when you're experiencing this from an endometriosis component. So the dysmenorrhea and dysmenorrhagia, the heavy periods and the painful periods, then we sort of move into the aspect of the penetration and other movements related to intercourse and how that can pull and stretch the endometrial tissue, and especially where it's associated within our abdominal or pelvic cavity, and how that impacts us from a position, a sexual position point of view. And so it is trial and error with that, sadly, but let's see if we can give you some answers. So the impact of the endometrial pain, what does it mean for the partner? How does it affect your partner? How to minimize that endometrial pain during sexual activity. Now, it doesn't have to be penetrative sex, but sexual intimacy in some component. Often, your partner either is brave enough to say this, or they're thinking it, is the pain real and is it that bad? How long does this last for? This could be anything from menstrual pain to your moods, to how it distances you from an intimate opportunity. And they might be wondering, is it always going to be like this? This puts a lot of strain on relationships, trying to establish the relationship or to sustain it. And so from that, we're looking at, well, they'll be wondering, how often am I going to get sex? And you're wondering, how often can I be intimate? But because this is horrible, this is not fun, this is not something I look forward to. And how it impacts the intimacy. So what's on the table? What's the compromise here for your partner and for yourself? So how to look at that communication. You're going to hate that word, but it is so important about communication styles, tones, words you'll use to try and get something across from that point of view and describe what you're feeling, which is super difficult to describe. Position, 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 sexual position, sexual compromise, sexual toys, things that can be done to maintain intimacy and still level out that discussion of pain. What about negotiating and redefining sexual intimacy? So I'm all about trying to redefine what sex is, what sexual intercourse is, what sexual intimacy means for people. And from a partner perspective, whatever sexual orientation your partner might be and what you're experiencing in this period of this endometrial journey, it's like, how do you define intimacy? Because it's different for you, it's different for me, it's different for the partner. And so that compromise in that communication style is about trying to establish what that intimacy might mean for both of you, so as you can put something on the table there. My little cartoons, my uterus is shedding, I will not hesitate to stab you. I know that I've felt like that many a time over the years. So why can't you just cope with your periods like other women do? I've been told that many years ago, and it doesn't wash well when you're experiencing that endometrial pain. The period pain associated with endometriosis can be severe abdominal pain that can be for a couple of days in that month, or it's this rumbling of discomfort and annoyance, if you like, and then it becomes excruciating when you're close to and when you're experiencing your bleed. So some effective release and management is available. It's not always and will not always be able to provide a significant pain relief for everybody, sadly. But it is about knowing your options, and it's important to be aware of all your options, the limitation of those and the disadvantages as well as the advantages, but the disadvantages of some of the treatment. I know most of the time people are explaining endometriosis management from that biomedical model, and it's surgery and it's pills. So, and pain management from a pills point of view. So this is looking at all the disadvantages and advantages of trying to come to that compromise of it. Never feel bad or guilty to ask questions. Always, you need to be armed and dangerous with your information that you can take on board and how you adapt that to yourself. So my question here, what can I, meaning the person with endometriosis, and we do when sex hurts? Pain with intercourse or dyspareunia is different for every woman. It is always different for every woman. We can be similar, but we're not going to feel that same level of discomfort or pain. It might be mild or sharp or stabbing. It might be deep and widespread and aching with that constant ache. Maybe only pain with penetration, and that can be fingers, a toy, or a penis. Pain can be associated with very deep penetration and with or without orgasm. So that's really interesting and really relevant to know when you're feeling that, because sometimes with that compromise of intimacy, we actually, it's like, you know, a little bit of pain, you'll go, okay, just bite the bullet. Sadly, sometimes we have to do that. And sadly, it becomes a habit as well for a lot of people. So when we're talking about orgasmic pain associated with endometrial tissues, it is something that I really, really believe in about mindfulness exercises. And that's something probably that Meg will go through. So I think that mindfulness really helps manage that orgasmic pain and that deep penetrative pain as well. Some describe the pain only during the actual intercourse, but others can describe it that it lasts for hours after sex and sometimes up to several days. That is not unusual, sadly. It depends on, again, where that tissue is and how bad it is and what else it's pulling at. Most of the time, it can be linked to the location of where that specific endometrial tissue might be, rather than the size of the endometrial lesions. So sometimes when you've had a laparoscope and they think it's not very bad, you know, what we can see as a surgeon or a gynecologist, and, you know, maybe we might leave well alone, or they might offer you some ablative therapy to burn it away. But it's actually where that tissue is situated that's going to cause you the discomfort with sexual penetration and position. So sometimes it's that juggling component of just about standing on your head, sometimes about trying to find that happy space of where it's okay to first with sexual entry, and then you find your other positions to enjoy sex with. If the endometrial tissue is linked behind the vagina and the lower part of your uterus, it can be affecting the uterine nerves and or ligaments there. So sexual penetration is more likely to be associated with significant pain. It's usually associated with a thrusting rather than a rocking motion. So the thrusting during sex is going to push and pull that from it. Also, aggravation is multiplied with a dry vagina. So some of the medication and pain medication might actually contribute to that dry vagina. And so lubricant is really, really important when you're trying these things. Lubricant's really important. The good old silicone-based lubricant or water-based, old-fashioned water-based lubricant's probably the safest. Because if you're on certain medications to help you with pain as well, or antibiotics or whatever, for whatever reason, it can enhance this sort of different lubes if they're coloured, if they're flavoured, if they're scented, if they've got fancy things in them. And the same with condoms. Some of the flavoured and or the different lube that's already on the condom, it can cause more of an aggravation in the vaginal tunnel. It can cause you thrush, like chronic thrush. It can cause you urinary infections. It can also cause you bacterial vaginosis. So you've got to be really mindful you don't get a double or a triple whammy with your pain you're already experiencing with your endometrial issue. So really old-fashioned water-based lube or straight up silicone. Silicone's really good because it can go a long way. It just needs a little bit of spit, literally, to lube it up again, instead of applying lots and lots of KY jelly or water-based lube, where that can actually get a bit dry after a while, and it can roll up and cause irritation as well. So it is trial and error, but remember, it's also about the condom. What type of condom? And we all think, you know, the fancy rib, the flavoured, everything's nice, but it can actually cause you some irritation. So getting your partner to take the situation seriously with endometriosis is something you have to deal with together. And it's not straightforward for some, because sadly, some of them are just not going to get it. Invite them to your GP appointment, invite them to your specialist appointment to help someone else, a third party sometimes, to assist with understanding your symptom, the diagnosis, and how it impacts your whole life. Because sadly, a lot of the time it does. So if you're sort of just, you know, trying to cope with your endometrial pain, with pelvic pain, your period, and trying to manage that, and then trying to manage sex as well with it, and you're emotional, you're tired, you're cross, and they're thinking, oh, here we go again. So shut that down and take them along with you to a specialist or an allied health person to help with the explanation. See if there's a support group. I don't know, Kat, are there support groups for partners? That's something that might be worthwhile looking at, because no doubt at some stage they're all going to feel the same like you do as the person with it. So the partner might be frustrated and think, I don't know how to help you. I'm frustrated as well. But maybe that's something down the track that could be looked at. The dyspareunia, eventually, if you're experiencing this in quite a severe way with this endometrial pain, it becomes a barrier in itself with fear and anxiety and preempting that pain. It's that anxiety-driven, it's going to hurt, why bother episode. And that increases the issues around your sex drive, because you just go, it's just too much for me, this pain. So therefore, this is just too hard basket to even try. Becomes frustrating for both. The communication's lost. There's avoidance in the intimacy. There's avoidance in the communication overall. It's a vicious cycle. So it's like, you know, we've got to try and keep the intimacy on board. Don't worry about the penetrative sex too much, even though that's the icing on the cake at some stage, but it's about the intimacy, how to maintain that and find out where the go zones are. So who are the allied health professionals and how can we help with the endo? Well, of course, me and the physio and the clinical psychologist, pain specialists. What else can be done? These are helpful, and it's all about keep moving, as Kat will always say. You've got to keep moving to help with the discomfort, oddly enough. It might seem like you just want to curl up into a ball, but actually that's what you need to be doing, is keep moving. My little cartoon again, yes, you know, our female problems are seen as a nuisance most of the time. Why I've got this thing up here, coital alignment therapy. So I'm always talking about intimacy. I've talked in the past about body mapping tool and finding out your other sensory zones, about touch, smell, taste, intimacy, and how to explore that in a different manner, and how to, you know, get on board with that and to see what's happening. Coital alignment therapy is another way. When I talked about where that endometrial tissue is, and if it's behind, tucked behind that uterus and affecting the nerves and ligaments there, coital alignment therapy is one of the things you could try. Now, it is about a rocking motion rather than a thrusting motion. So you're the person on the missionary position here with the endometrial issue and the pain with sex. So what happens here, you can have outer course or you can have intercourse with this. So the idea is the person on top is a little bit above your pelvic bone. And so basically if they were lying on you, their shoulders are up around your ears potentially. So it's about their legs are straight and yours are parted. And they can park if it's a penis, if it's a sex toy, if it's digital, if it's fingers at some stage, doesn't matter. But what happens is it's pelvis on and up around your clitoral area. And so it's this rocking motion. If it's penile insertion, so you guide that penis in, and if the deepness is a problem, you can use donuts, like you can order those on a sex line. So they're little rings of either silicone or latex, and they're parked on the penis, and it's like keeping the penis only inserting a little bit or all the way. And so it's keeping that barrier back so the insertion isn't as deep. And so if the penis is inside the vagina and it's this rocking, now the female underneath here is putting a little towel, a roll towel or a cushion in the small of your back so your pelvis is tilted as well. And there's this rocking motion, and the rocking can speed up, and then there's this rubbing on that clitoral region, and it's causing stimulation for both. And I think it's Rosemary Basson is one person that described this really well. And it actually does increase orgasmic opportunity up to, in some cases, 80%. So if you want to give it a go, it does take a little bit of practice to master this position. But if you look at coital alignment therapy, that's what it's called. Not cat therapy like in psychology, Meg. It's different. It's like, so if you look at that, and then if the female brings her legs in and over the knee area to sort of, you're wrapped around, and that becomes tighter. Now, if you want just outer course, the penis is just parked between the labia with lubricant. And again, it's just this rocking motion. Might help, might be another way to enhance opportunity of intimacy, but with a sense of sexual penetration in that aspect. There's my little thing, it moved, good. So the other thing is...
Michelle?
Yeah.
Sorry to interrupt you. We've just had a reminder that there's a non-binary person listening, and they just like a little bit more inclusive language if possible, please.
I apologise. Thank you.
That's okay.
With the types of orgasms that people can experience as well, and be mindful about the different types of orgasms laid out here. They can cause cramping and sort of spasming of the uterus. And this is where mindfulness really helps with this. And you've got to be careful how your body is responding to that level of orgasm, or if you need to control that orgasm and stop it. And certainly some people who I've discussed with the convulsing type of orgasm causes a lot of pain. And so mindfulness has been super helpful in slowing that down and controlling that level of sort of just with the pulsing of the smooth tissue of the uterus, and causing that issue, which is causing a delayed reaction of pain that can last for several days. So that's why I've put this up here, just to be mindful of, if you're going to go down that road of wanting to experience different orgasms, be mindful, and be mindful how that can cause pain or wherever your endometrial tissue might be located. And if you're lucky enough to know where that might be. But with any intimate touch, and whether or not, there's any exploration from an intimate manner with the vagina, or if there's sex toys shared by couples, you will learn what's acceptable. Worse luck, you're going to learn the hard way most of the time about where your pain is felt, how you need to express that, and how you can manage that with sexual intimacy and exploration. But understanding the type of orgasm is really helpful to understanding how you can breathe through it, how you might work through it, and how you can understand the sensation as it begins and stop it. But that's where the mindfulness can come in, and it does work well. Okay, so that's me. I finished early, haven't I? So hopefully there's been some answers for you, or ways to think about how you can express intimacy and share that with your partner. and where that might lead you with conversations to explore that even further. So, okay, that's me.
Thanks, Rochelle. To answer your question about support groups, I'm not aware of any partner support groups that are around.
Yeah.
When we used to be in person, we had some partners turn up, but since we've gone online, it's been more just people with endo. But yeah, certainly it's a space worth exploring, I think.
It might well be. Yeah, and I think, I think there must be a lot of partners out there a bit frustrated as much as the person experiencing the endometrial pain, and how they might support one another in a way.
Mm-hmm. Did anyone have any questions for Rochelle? You can either ask through the chat and I'll read them out, or you can unmute yourself and ask a question if you would like to.
Not yet?
Not yet. All right, we'll keep going. And if you've got any questions, just put them in the chat and we can come back to them. Our second speaker is Meg Odgers. Meg is a clinical psychologist based in Geelong. She completed her Master of Psychology postgraduate degree at Deakin. Meg provides evidence-based psychological interventions to young people and adults experiencing mental health concerns. She values holistic health and uses a relational approach in working with people experiencing a range of concerns. She utilises several treatment approaches to support people to process their experience and to enable them to reach their goals. Her areas of expertise include depression and anxiety experiences and disorders, trauma-related experiences and disorders, persistent pain, and personal development and growth. Meg enjoys reading and learning about various fields within psychology, including somatic and body-oriented approaches, attachment and parenting. Is it existential and transpersonal psychology? I hope I've got that right, Meg. She maintains her own mental health and well-being through practicing and teaching yoga and other contemplative traditions. Just checking whether a question came through while I was reading. There was a question, I'm not sure if Rochelle is there because her camera is off, but if you are there, Rochelle, is there a preference between oil and water-based lubricants?
Oh, well, definitely. If you're using things like dental dams or condoms, you wouldn't want to use oil-based because that'll disintegrate the protective factor. So water-based is a lot better if you're using a barrier method of any sort. But if you don't need to use a barrier method of any sort, what you can use, and it doesn't cause any issue and it goes a long way, is almond oil. Almond oil doesn't have a scent, doesn't have really a taste, and you only need a little bit and it goes a long way and it lasts well. Yeah. It doesn't cause those things like thrush and bacterial vaginosis either.
Feedback was really useful. Thank you.
Okay.
Meg, we're ready for you when you are ready. Your presentation's looking good. Are you with us, Meg? You're muted. We can't see you.
Thank you.
That's okay.
Saying that this is my first time using Apple presentations, not Microsoft, whatever it's called. So I'm still getting used to this. So I'll just start my share again. Sorry about that.
It's okay. We're all learning together.
So thanks for the introduction, Kat. Yes, I am practicing as a psychologist in Geelong. It's really lovely to be here. Can you see that now?
Yes, we can see your presentation, but we can't see you.
Yeah, I'm not sure why that is. Apologies.
Okay. That's all right. You've got a lovely photo anyway.
Yes, I can hear you also. If you do have any questions throughout, please just interject and ask. So I've already been introduced. Kat's already acknowledged the country, but I really think it's important to continue to acknowledge that we are gathered here today on stolen land. And like Kat said, there's a whole subsection of the community that we don't really know about because we don't hear the stories within of Aboriginal and Torres Strait Islander people as much as we need to. We really need more truth telling, more deep listening, to understand and bridge the gap and honour the Uluru Statement of the Heart. You're the expert of you. I'm a early career clinical psychologist. I still have a lot to learn, and my, I guess, expertise, if you will, is really in trauma theory and therapy, and my generalist clinical pain skill set is based on the fact that I work in a public pain management unit, which takes referrals from every sort of pain syndrome, not just pelvic pain. So pelvic pain is obviously a subspecialty, but I still think that the pain concepts that I can cover here today are relevant and hopefully helpful. And I just want to acknowledge that I stand on the shoulders of giants. In my early career, I've been influenced by Anita Elias and Dr. Sarah Ashton, both in Melbourne, and also more locally, Marilla Druitt, who many of you will be familiar with, Joe Sheedy, my supervisor, and Rochelle herself have really supported my understanding of pain and pelvic pain from a clinical perspective. And obviously I'm learning from the people that I have the privilege of supporting. I have family and friends who live with pelvic pain, and my own experience of having a vagina and a female body, obviously. So often when it comes to women's health, we're hearing about, you know, from men's perspectives, male perspectives. So it's really important when it comes to women's health to have that inclusive and lots of diverse voices. And we're all learning from each other. This is intended as a perspective, some education. It's not a substitute for medical advice or getting your own therapy. And it's all been compiled in good faith. I don't have any significant conflicts of interest. I guess I will say, though, because the nature of the topic, pelvic pain and sexual pain, you may feel activated and triggered at some points during these discussions. And if that is the case, do just take that additional care for yourself. I don't know who I'm speaking with, actually, so it's really hard to provide sensitivity and trigger warnings, but that's actually just not possible. So I would encourage you to be doing that self-monitoring and taking additional care as needed. So I hope I'm presenting a bit of a paradigm shift. I'm presenting a psychological model of care, not a medical model of care, because I've received zero medical training. Most people that live with chronic health issues are used to receiving a medical model of care, often to the exclusion of other models of care. And the psychological model of care can feel like a big paradigm shift often, especially when you've only ever received and been treated. Your health has only ever been sort of a medical issue. Now, the fact that I'm a psychologist presenting a psychological model of care, it actually doesn't infer that the pain is all in your head. Although that's something that I hear every day on the job, that to be referred to a psychologist must mean that my pain isn't real, or it's in my head, or it's not important. And I just want to highlight that this is simply a different way of understanding and treating pain than the medical model that is the prevailing sort of on the hierarchy. I know that your pain is real and valid, and at times it's really debilitating and disabling. So I just want to acknowledge and let you know that I know that. Pain is really complex, and there is almost always several contributing factors. And like I said, I don't know what any of those are for you, because I don't know who you are. We haven't introduced ourselves. I don't know your name and your story, your history. And in modern fast thinking society that we live in, we don't actually have much room to talk about the complexity and nuances of pain. But I will attempt to give a kind of broad, sweeping approach of how I understand pain to the best of my ability. So within my training, like I said, I don't have any medical training whatsoever. in my, several years of training as a psychologist, I have learned the biopsychosocial model of health, the biopsychosocial model of all sorts of mental health conditions, but we can also consider pain, including pelvic pain, from a biopsychosocial approach. And this is a little diagram from Noi Group, Neuro Orthopedic Institute, and they are the leading kind of experts in pain science for the last 30 years. And you can see that with health at the centre, there are biological factors, psychological factors, and social factors, and you can read them for yourself there. But generally speaking, within all health presentations, there are all different sorts of contributing factors. And, my area of expertise obviously is within the psychological and social rings there. And it's interesting because, often it's the lack of knowledge, the lack of family, friends, colleagues, their support, social support. It's feeling connected within a consumeristic, capitalistic culture, society, feeling lost and purposeless in community. These sorts of things, they seem like they might not be relevant, but the stress that they add to our lived experience means they become incredibly relevant in the psychological management of pain. And so one of the first pain concepts that Noi Group have kind of championed is that pain is a protector. And, I want to acknowledge that most people are used to approaching their pain as if it's a problem to be solved. But the idea of this sort of first pain concept within a pain education approach is that the severity of the endo is not necessarily a reliable indicator of the pain you experience. And, I guess one of the examples that we give of this, and that people well know within the endo community, is that some women or people with endometriosis, I should say, might have, small amounts of endo within the pelvis, or like Rochelle said, within the any of the cavities, the abdominal or pelvic cavity, and experience debilitating pain. Whereas someone else with large amounts of endo, heaps of lesions, might experience no pain and maybe only discover that they have endometriosis if they have, say, cesarean section. And how could that be? That's baffling if we only look at pain through a biomedical model. So I talk to people a lot about considering pain as a phenomena in and of itself, to be understood and respected in its own right. And a person's pain is personal. Yeah, it's unique to them, but the one common factor is that pain is a protector. And I know that can be really difficult to even consider. It's a big paradigm shift. So I just wanted to check in, and I can't see messages, so it would just have to be, through Kat or whatever. How does that feel to consider that pain is a protector? Anyone's yes to share? And, it might be that people feel confused by that, feel angered by that, feel invalidated by that, feel curious about that. Just take a minute and you don't even have to share, just sit and think, how does that feel to consider my pain as a protector on some level?
Someone has contributed that it feels like there is probably some truth to that, and highlights the need for mindfulness. Someone else said it's really interesting. You always feel like pain is something to fix. Yes, I love that. Yeah, it is, because within the biomedical and hypermedicalized society, we certainly kind of implicitly kind of get that message through advertising even of pain medications and so forth. So this, like I said, this is a big paradigm shift, and thank you to those who've sort of shared some of their thoughts and feelings about this new concept. I guess the 101 of kind of pain science, and again, this is really overly simplistic. It's not personal to you. It's generic information I'm providing here. But all pain is made in the brain and felt in the body. And there's a protective
biological mechanism, and this mechanism is in the service of our survival. This pain, ultimately, from an evolutionary perspective, is in the service of our survival. All pain is made in the brain, but so are all our other survival functions. So is our thirst, so is our hunger, so is our sleep drive, so is our sex drive. They're all made in the brain. It's just that somewhere down the line, people decided to stigmatize and make it kind of a mental health issue that pain is made in the brain. That's like saying that, you know, thirst is a mental health issue. No, it's just a survival function that happens in, you know, in every area of our brain, the service of survival. Persistent pain is usually, often, and this is, you know, getting into the high sciences now, associated with a thing we call central sensitization of the central nervous system. And we could say that our persistent pain is our nervous system becoming, or having become, overly protective. Yeah, and I'll try to explain that as we go through. There are many biological, psychological, social. If we go further, there's cultural, there's medical factors that contribute to this increasing sensitization of the nervous system over time. Developing persisting pain and the process of central sensitization is an unconscious one. That's why I said I know it's not all in your head. No one chooses for this to happen. No one chooses for pain to develop or for their nervous system to become overly protective. It is purely unconscious in the service of survival. However, understanding the science of pain, and that's why, you know, prevention and educating people early is so important, and the reason why we, you know, come on to talk to you on Sunday afternoon, because we want to, you know, get this information out to people, you know, as a preventative measure as well as, you know, intervention and support down the line. But it's essential in the psychological management of pain to really understand pain, not just from your own lived experience, but what scientifically has kind of contributed to your experience. And that can help to kind of psychologically diffuse a little bit from what feels like the messy, fast vortex of your own pain experience. Learning about the pain science and realizing the commonality of across pain syndromes can be helpful for some, not everyone, of course. And when we understand more about pain, we can often feel less fearful of it. That frees us up to move more. And as Rochelle and Kat have talked about already, movement is so essential. We worry less. We might give up the search for a magic or medical cure, and maybe even experience less painful sex. And I just want to highlight that in our tick box, you know, one and done kind of, you know, culture, we can sometimes think, oh, if I just kind of read that book about pain education, I'll be done. I'll never have to kind of do anything else. This learning and exploration is really ongoing. And the more that we, like, the mind-body connection is so fascinating, and we can go down this endless kind of rabbit hole. But really starting with pain education, pain neuroscience is a fantastic place to start and essential in psychological management. And I've taken this image as well from Noi Group with paid permission. And this is from their book, their workbook called Protectometer, which I highly recommend to all pain sufferers. And you can see here that Noi Group have split different signals of danger and safety, because if pain is made in the brain, you know, it's the brain is also something that is constantly scanning your environment, your body, your nervous system is always scanning your environment for signals of danger and safety. That's its language that speaks. And so Noi Group came up with this concept of dim sim therapy. We're just going through daily, if you have the time, and figuring out what were the dims that I experienced today? What were the sims that I experienced today? Because if I'm experiencing more danger in my daily life, if I'm hearing really scary things, seeing really scary things, believing really scary things, going to really scary places, having really scary people in my life, scary things happening in my body that I don't understand the science of, I can obviously expect to be experiencing a hell of a lot more pain that feels even more severe than usual, maybe flares me up and interferes more with my daily life functioning. And then on the other hand, you know, there's the Sims, and they, of course, can help us to feel more safe within our body, and therefore, like, increase our feeling of coping with the pain, if not even make us feel, I don't want to say pain reduction because it's not necessarily the goal, but it just puts us in a different state, and we can enjoy life more. And they've split those down into several categories, which just really help with the mapping out of what are the unique contributions. What are the things that are dialing up your pain from day to day, and what are the things that dial down the pain from day to day? In my work, it's another really big thing that has to be covered is the stress-pain connection, because both pain and stress are central nervous system, brain-based phenomenon. People living with chronic pain and other chronic conditions like endometriosis, these are inherently stressful. Even we could say living with endo or living with pain that persists is traumatic, depending on your own experiences. If you think it's traumatic, it's traumatic. And stress management and trauma processing may be important components of your pain care. With everyone I see pretty well, I go through polyvagal theory. Some of you may have heard of this. It's becoming kind of quite popular online. And that's because it's essentially providing a map of our autonomic nervous system. And so I don't really have time to do this justice, but I love this image because it demonstrates and shows in quite simple terms what is actually a very, very nuanced, complex, sophisticated survival system. And so you'll see there at the bottom, the green zone, the ventral vagal component of the vagus nerve. So I guess that from an anatomical point of view, we all have a vagus nerve. It's the thickest, longest nerve in our body. And I think it sort of runs down the sort of spinal column. Someone might correct me if I'm wrong with that. But the part of the vagus nerve that denervates the face, yeah, and that's how we know that someone is friendly, because they kind of smile and their eyes kind of move in a particular way and the tone of voice is quite soft and welcoming. We get, our nervous system reads, that person sounds safe, that person looks safe. That's an unconscious process. But when we're in that social engagement system, it's very easy to kind of attune to other people and to feel very open and mindful and present with them. Okay, and you'll notice on the left-hand side that the arousal level is very low when we're in our social engagement system, when we're in the green zone. It's all about safety and connection, where we're feeling safe in our environment. Now, our sympathetic nervous system and dorsal vagal nervous system, or states, I should say, in terms of anatomically where they sit. So the sympathetic nervous system from the vagus nerve, vagus meaning is Latin for wanderer, and that denervates the kind of chest and arms. So when you're not in a stress state, it will energize you to be able to go for a run, to dance, whatever it might be. And I guess also I really need to point out the dorsal vagal part of the system denervates the gut. And it's really interesting because some of the latest research is showing that the lowest point of the vagus nerve in terms of where it denervates is the cervix. Yeah, so it touches the cervix because that's how low it goes. And I guess I want to point out that, you know, we experience these states not under stress and under stress. They're two different kind of mechanisms. One is for, you know, enjoyment and daily life, different kind of intensities of that. And the other is about survival and running a stress response to help you survive. So an example of a dorsal vagal experience not under stress is like a deep meditative state, yeah, where you just feel so peaceful and at ease, and you're immobilized but not in danger, immobilized with this sense of presence and safety. But what's when we talk about pain, we need to talk about the stress and trauma responses, which are classically fight and flight. So when we're in high school, we learn about the nervous system. Those of us that went to high school, we learned about fight and flight and rest and digest, which I think they were referring to the social engagement system. And you can see how as arousal increases, as the threat in our internal environment or our external environment increases, so does the intensity of the fight-flight system. But what we never knew until kind of Stephen Porges came along and he developed polyvagal theory is that we also have a second parasympathetic system, hence polyvagal, second parasympathetic system, and that is dorsal vagal. And dorsal vagal under stress is all about our last line of defense, our emergency state. When we're in a freeze response, an acute freeze response, we can feel immobilized, dissociated, completely shut down, sort of feels like lights are on, no one's home. And we can actually, with sort of chronic stress and traumatization, we can live in this state, actually, in sort of more of a functional freeze response. But the good news is that there's ways and means of supporting our re-regulation of our nervous system. So by the time we're living in a chronic fight, flight, or freeze response, there's a chronic dysregulation of the nervous system that happens, and it's a ripe environment for more severe pain that interferes more in daily life. But there are things that we can do to help re-regulate our system. Yeah. And like I said, I could really do so much more education on this, but time just doesn't permit. If you want to know more, all you have to do is Google polyvagal theory. Now, as we go into more of the specific stuff, I guess I want to point out that many of us actually don't know much about the anatomy of our sexual organs and so forth. So I just wanted to point out that there's this beautiful artist who does these really lovely illustrations, and you can see her brand down the bottom there. I've paid and purchased these designs by Duvet Days, and I just find them very informative and I think that when we're not medically trained and we're just depending on our information to come from other sources, it's really hard to talk about painful sex and relationships, and we actually, don't know where different parts of our body are and all that. So it's really important to understand our own anatomy, and this can be a non-threatening, quite engaging place to start, just studying the anatomy through these sorts of illustrations. Flying through. Kat, am I going okay for time, or should I start to wrap it up?
I think you're going okay. I'm just having a look. It's 4 o'clock, but we've got plenty of time.
Fantastic. All right. And everyone's still awake? Because I can't see them, so I'm hoping they're still awake.
I'm assuming that they are.
Awesome. So I did a bit of work, a workshop last year with Dr. Anita and Dr. Sarah Ashton, as I mentioned, and they talked a little bit about, the brain is the most important sexual organ that we have, and our mind-body connection is it's infinite in its capacity. We have so much there's so much we don't know about our mind-body connection. We kind of talk about them as if they're separate things, but they're actually so overlapping and interconnected. So I loved this sort of little diagram that she did, because I guess that first point is, if we feel that sort of sex is out of duty, it's a should, it's a chore, we've bumped into our first kind of hurdle. We don't feel free. We don't feel free to have sex or not have sex. Yeah, so that is the first kind of hurdle that we sometimes bump into. And then, of course, we can feel worried, stressed. We can run a stress response. We don't feel safe because we're in fight, flight, freeze, maybe chronically. And so that adds perhaps a tension to the pelvis. Like I just showed, the pelvic floor, as Celia is going to go into, is really, really like incredible muscle and soft tissue and that go on there. It's fascinating. But of course, you can imagine that all can get really, really tense and actually can feel really difficult to relax that pelvic floor. if it's chronically tensioned under a chronic stress response. Naturally, if that's the case, psychologically there's like a lack of sexual arousal, there's a lack of sexual desire, and sex can feel either painful or actually like an anatomical impossibility. Okay, so the first thing Dr. Anita, this expert in pelvic pain, says is, first thing, we need to feel free. We need to know when sex feels like a yes, and we need to know when sex feels like a no, and honor that. And then it's about building safety, relaxation, arousal, and then we can experience enjoyable sex. And I think that Rochelle's work with developing the body mapping tool is really, really important in terms of, once you decide, yes, sex feels like a yes for me, it's a really good, where either by yourself or with a partner, exploring what feels safe, what feels relaxed, what feels good to me, and being able to communicate very clearly, that's a yes for me, that's a no for me, either to yourself or to a partner. I guess one of the really common words, like Rochelle mentioned, that people hear is vulvodynia. You can read a little bit about it there. But I guess we've speculated, no one knows, even the best medical professionals don't really know what causes it, but we speculate that having unaroused, poorly lubricated sex might be a significant contributor, as can common infections like candida might be a thing that starts this sort of initial tissue damage. But as you know, if you've been paying any attention so far, what might start the pain, precipitate the pain, can often become very different from what goes on to perpetuate the pain. And so that's really demonstrated quite nicely by this slide, which again is stolen directly from Anita's PD. Sometimes there's a clear precipitant to vulvodynia, other times there's not. But as the person suffers more and more with the pain, that's sensitization of the nervous system happens peripherally, and then can happen through the biological, unconscious, protective, defensive process of central sensitization. And of course, there's this feedback loop that we feel really stuck in and spun out by. The other one, of course, that people hear about and experience firsthand is vaginismus. And we've got the DSM-5, I actually think it's the DSM-4, because we don't actually refer to it as that in the Diagnostic and Statistical Manual anymore, because I checked yesterday. But something that Rochelle and I talk about a lot at work is the psychosexual contributing factors or causes, contributions to experiences like vaginismus, and you can read about them there. And I think it's just important to again highlight, I don't know, I'm not suggesting that these are your contributing psychosexual issues or factors, but they're just some of the common ones, and to an extent we're all influenced by, we all suffer within a patriarchal, misogynistic culture. We can internalize a lot of that, and that is really deep sort of psychological work to be discovering and working with some of those things. Often within psychological management, we are talking directly about the fear, the stress, the anxiety of the unknown, or hang-ups about not being good at sex, or the predictions and anticipation and anticipating painful sex and so forth, and of course abuse. And Anita, again, just gave this great slide that helps to kind of demystify a bit of what's going on here. And she used the analogy of vaginismus, the unconscious reflex of the tensioning of the pelvic floor muscles, as being like the mechanism of blinking. Like you blink to protect your eyes, and you do that unconsciously. You don't have to think about that. But when there is conscious fear or a history of trauma or whatever, you don't have any say. The muscles are just unconsciously reacting and protecting based on the best information it has, which is often what happened in the past. And I guess moving on to what this means for your relationship or your sense of being a sexual being, having a sexual identity. If you don't know how your pain behaves, it's really hard to communicate needs to a partner, or even just identify your own personal needs in your relationship with yourself. And partners can find it difficult to empathize with things they don't understand. Sex and relating becomes stressful. Fear and worrying and anticipating painful sex really obviously exacerbate pain because the stress and pain connection. And of course, there's an unconscious associations, there's neural networks, there's like habitual learning about sex and pain. And so, you know, Rochelle and I work quite closely together, and we talk a lot about ways of helping people to develop more emotional safety and intimacy, including non-sexual touch and affection, like Rochelle's body mapping tool. Part of working with a psychologist in couples work might be learning to fight fair, to take some of the stress out of conflict. Anything that creates more safety in me within that dim sim therapy can help to slowly break down associations that you might have between sex relating and pain, and maybe somewhat retrain the brain and central nervous system. And Rochelle also mentioned this, but having partners attend appointments can be really helpful because they have their own experience of this, and they might have their own questions. And with a little bit more education and understanding and insight, it might make a world of difference to the way you relate to each other. And so it's really important to just talk about sex. Sex, of course, is very taboo in most corners of the community. But pain can impact every aspect of our sexuality. Breaking the cycle, if we were to really oversimplify it, it would be to stop doing things that hurt and to start doing things that feel good, safe, and fun. And you will have to, perhaps, depending on how far you are down the road, perhaps really take on a beginner's mind in exploring that for yourself again. And when it comes to talking to professionals about sex, again, because sex is often taboo and painful sex perhaps even more so, if your practitioners, aren't asking you about sex, you might, want to ask them, could we please talk about sex? Because there's all sorts of models, within sexual health to tell us that it's, the first thing is having permission and mutual respect in talking about sexual issues. And so from a psychological perspective, there's lots of treatments available, varying degrees of evidence, pain education. There's some of it is freely available through NOI Group, but there's various, especially physios, trained to provide NOI-based education. Cognitive behavioural therapy is the bread and butter of psychology, and there is some evidence of CBT for pelvic pain. I'll talk a bit more about that later. And these other ones, they're fairly self-explanatory. I think it depends on your presentation, what's in your history as to what treatments you might seek out. EMDR and somatic experiencing being more trauma-focused treatments. Emotion-focused couples therapy can be a wonderful way of working out your communication styles and so forth. And you might like to screenshot this. This is just a couple of pelvic pain and painful sex resources. I haven't read all the books, but I have been recommended a lot of them. And I think it's just helpful to surround yourself. We need to resource ourselves with as much education, and we need to feel supported, because what does that do? That helps us experience a sense of safety. It's a ventral vagal state when I feel empowered, supported, like I have the latest knowledge and education. These can all be very protective. And I have a more generalist pain resources list that I've compiled over the years, and I'm happy for Kat to email out to people. In terms of more direct psychological management, I think you've all heard of the HAPPY study, but the details of it are there. I'm finishing up my second intake, and it's been so much fun. And this week I recorded a podcast on this very topic. So again, you can go and find that one and listen to that one. Any questions and feedback at this point? I'll stop my share.
Not seeing any questions yet. Oh, yes. Someone's just said very informative. Thank you, Meg.
Thanks, Maddie.
Can I just point out, Meg, thanks for raising the polyvagal issue in relation to that. And some people who experience really severe endometriosis, one of the early symptoms is the gut issue and irritable bowel syndrome.
Yeah.
And sometimes that gets pushed to one side saying, well, that's what you've got. And they don't worry about your period issue or your probable endometrial component. So with that polyvagal theory and concept of that and gut training, and especially if there's any endometrial tissue along the bowel wall, and that can sort of help with managing some of that endometrial pain as well with that. And that's where I think things like mindfulness can also contribute to something positive about that. Yeah,
absolutely. Because the more we understand what state we're in, like if we have an idea of what different states there are, what different stress and trauma states there are, then we can recognize when we're in them and that we might have to do something about it, either through self-regulation or co-regulation through mindfulness and so forth things.
Yeah.
I hope I didn't run too far into Celia's time because I'm so excited to hear from her.
No, we've got plenty of time.
Oh, good.
Thank you, Meg. Hi, Celia. Thank you to everybody for your patience. Celia found her way in to our Zoom meeting. It turns out there's a new Zoom problem where occasionally this happens and Celia was being told that I was in another meeting. So anyway, we workshopped it in the background and she's found her way, which is great. Our last speaker is Celia Bolton. She's the founder and director of Inner Strength Healthcare and the mother of a teenager. She graduated as a physio in 1991 and has lived in the Geelong area since 1998. She's been working in the area of pelvic health since 1996. Celia has furthered her tertiary studies to increase her knowledge, including women's studies, continence and pelvic floor rehabilitation, and exercise for women. More recently, she's become a certified Giant Mind meditation teacher, studied trauma-informed care and family violence to complement her passion for mind-body holistic care. Thanks, Celia. Great to have you.
Thank you for having me. Oh, this has been really good. Thanks, Meg. Thanks, Rochelle. That's been fantastic. It's so nice to see. We didn't actually prepare before and talk to each other, but we're really on the same page, which is very reassuring, which is fantastic. All right, I've got a little PowerPoint there. Just got to share it up. Some of this is going to feel a little bit repetitive from Meg's talk. I'm completely sure that we can benefit from hearing something a few times, and yeah, we'll just go from there. So this is talking about painful sex with endometriosis. I also always think with this that when we're talking about pain and sex, that you can actually feel triggered. And I just really hope that you have skills of self-care or people that you can reach out to if this is feeling a little overwhelming. And I've learned from some amazing people. Carolyn Vanderken, I've recently done this course that had me up at 3 a.m. because it was in a different time zone for the last 4 weeks. It's been beautiful. She's an incredible physio where she's really pioneered research in biopsychosocial model for pelvic pain, and that was amazing. And I've fangirled Lorimer Mosley over my lifetime. And obviously I've really learnt from meditation. Beth Shelley's another fantastic person. Adrian Lowe, who's got a book about pelvic pain, and Helena Frawley, who's a local person. I'm very grateful. And I just want to acknowledge country, and I pay my respects to elders, both past and present. And I think the connection that we all have with each other as humans, we just have to keep really bringing this back. And I just want to commend your work, Kat, because what you're doing is probably the two things that I think are most important in managing chronic health conditions is connection and exercise. And that's what you've spent your time doing. So just well done. Absolute respect. And again, as a physio, I was trained a lot more in the biomedical model, but it's so clear that with health and everything I read about pain and chronic conditions and lifestyle is that we really have to think big all the time, because it's if we're going to target problems correctly, we need to think big. So when it comes to sexual pain, often the focus goes straight onto the person that's suffering with endometriosis. I just want to bring it broad again. There's when sex is a problem, there's someone else involved, and they bring their own expectations and history. And talking to people, that is what you hear, that there are expectations, and culture has a really big role here. And there's a great book that I'm going to forget her name, Frances Darcy Teen's just put out about My Happy Vulva, and she's very much championing the role of, porn industry and Hollywood for our expectations of what sex looks like. So yeah, I wanted to talk about that. And like Meg was saying, I want to really just keep bringing it into that big picture that pain and nociception, which is the sort of the prior to pain experience signals in your body, is so intertwined with behaviour and thoughts and belief and emotion and context. And so we are not tissues, and we're all living in very interesting times. And sex is also a big part of the context we're talking about today. But our levels of stress are up overall because of the current world we live in. And if you're looking here, there's a lot that you can change, and we do lean very heavily on the psychologists in terms of their amazing CBT and trauma treatments to really help with behaviour and thoughts and beliefs. But education can do quite a lot there as well. And again, that idea of a cycle, and maybe you might have had an endometriosis diagnosis, you've had symptoms, and that is a journey in itself. There can be unpleasant experiences, and then worry and tension is created. And sorry, I just can't see my, what does it say under tension there? It hurts. What happens after that, Kat?
Yeah, it goes to hurts, then avoid,
Yeah,
reduced, and then up to reduced intimacy.
Yeah, I've just got the Zoom thing in the way there. So it's a cycle of where, there's worry, there's tension, it hurts, there's reduced intimacy, there's avoidance. And then we get what, thanks for talking about the DIMS, Meg, that new danger in me and the stress around what intimacy then becomes a bit of a threat. And then we have this anticipation, we have this protective. Remember where I've said pain is protective? It's sort of an output going, this might hurt. Okay, let's make this painful. And the cycle can go from there. And we are tissues as well. I wanted to say that. So there's a lot that goes on in the pelvis, and I wanted to show you some of the nerves that run through there. And so traditional biomedical models have gone straight for, there must be something wrong with the uterus if there's sexual pain, or there's something wrong with the vagina. But we're so much more complicated than that. We are complex and we are connected. And our nervous system and brain is influencing itself up and down and even outward to other people. And we have to keep thinking big. If you look here, the parasympathetic and sympathetic nervous system, which is our fight, flight, and our rest and digest, is affecting all the organs. You heard that from Meg too, part through the vagal nerve and partly all the way through the spine. So if you see there on the left, the bladder, the uterus, and the rectum have spinal projections, we call it, but there's nerves coming to and from, and there's conversations all the way up the spine. So now, instead of talking about our nervous system, it's there's a new field of science that's called psychoneuroimmunology. But even then, now they're bringing in the endocrine system as well. So we're no longer thinking nervous system. It's we're complex, and our role of our nervous system is to protect us. And if there's good evidence of danger, then there will be pain. And all pain is real. And I want to just keep that, it's not in your head. It's real, it's valid, it's debilitating, and it's not in your head. We have to just keep saying that. It's because it's easy to get that message when we start talking about nervous systems and central sensitization, et cetera, et cetera. And the three main themes that have come out of all the Noi work is they're really starting to drill it down for us. Is pain does not mean my body is damaged, and the importance of abandoning pre-existing ideas that pain indicates damage. It can indicate many things. In the acute phase, maybe damage, but it's not usually after the 6 to 12 week mark. Thoughts, emotions, and experiences affect pain, and the value of recognizing the multifactorial influences on pain. And the biggest one there is hope, that this is a learning system. We learn and change our whole life. We talk about our system being neuroplastic, so that you can, I've seen a beautiful video of a guy that was a cyclist and how he unlearned how to ride a bike. He actually wanted to prove that you can unlearn things, because it's really important. If we say that you can learn a pain protective reaction during intimacy, then it's really important to know that there is hope and there is some reversibility. We don't know how far, but we can retrain our overprotective pain system. The importance of conceptualizing pain as a heightened protective response that could be lessened. And that just came out recently. So big pictures, this is a bit repetitive, but pain protects us and promotes healing. And persistent pain overprotects us and prevents recovery. Many factors influence pain. There are many ways to reduce pain and promote recovery. And again, thinking about that neuroscience of pain and protection is very deep, like the blink response that Meg was talking about. It's not like you can go, it comes from my brain, I'm going to rational reason my pain away. It's actually not in that human recent part of the brain. It's right back in our deep autopilot brain. And so what Meg was talking about is creating safety. We have to, if we're going to unravel some of this, is there has to be credible evidence of safety in me, safety in me, safety in me all day, every day, as much as possible, for the system to go, okay, I can stand down now. So the idea, Meg said this as well, but on guard, we're in protect mode when we have pain. And there's some beautiful studies that looked at that. But what I want to say is it's bigger than, if you have vaginal pain, it's bigger than your pelvic floor, it's bigger than your actual vaginal muscles, etc. So that they found a relationship between involuntary pelvic floor muscle activity, muscle awareness, and experience threat in women with and without vaginismus. So it's one of those studies that you go, who actually said they would do it? But they were measuring how tense some people's vaginal muscles were and how tense their shoulder trapezius muscles were, and then showed a whole lot of videos about, non-threatening, threatening violence, and then erotic threatening. And they just measured people with and without vaginismus, which is a term just means tight pelvic floor. They actually found that both the trap muscles and the pelvic floor were tensing when there was perceived threat. And so the data support the idea it's just a general defense reaction. as a mechanism of involuntary pelvic floor muscle activity. So if you're in a situation where you feel unsafe, there is likelihood that your pelvic floor will tense, and jaw, if we think about it. I mean, most of us know where our tension sits, don't we? And they found that it was the upper shoulder muscles worked just the same. So it's just protection. And so sometimes there's an assumption made around sexual pain that there has been a sexual trauma, and that's incorrect, because if you've got, if you're spending a lot of time in your protective mode, then your pelvic floor could be tight for that reason. It could be any reason. Another study was found that vulvodynia, which means vulval pain, was actually more part of a whole body sensitization. So they found that people with vulvodynia had, if they had vulvodynia, they're more likely to have irritable bowel and whole body sensitization. So they were actually finding sensitivity on skin all around the body. So it's bigger than a local thing. It just has bigger consequences, of course. Now, I'm just having trouble moving on here. And here's this lovely polyvagal theory that I found so helpful in understanding and sharing. And Meg's already talked about that. But what I wanted to say is that meditation, mindfulness, and those sorts of things really power up your ability to understand and notice changes in your nervous system, and also learn how to deactivate. But more to the point, what I'd like to say is that social engagement is actually where intimacy lives. And oxytocin is our hormone that helps us with social bonds. And to actually be wanting to be intimate while in a heightened state, it just does make things a lot harder. And so we want to be in safety when really being able to connect. So it's not all about this big central pain being the factor for everybody who has endometrial pain related to sex. It can be mechanical pain, but what mechanical pain looks like, it's predictable and it's local. And so someone would say to me, when I do this, then I feel that. And every time I do this, I feel that. And it settles quickly when I stop. And I meet people like that all the time. So for instance, someone might say to me, when my hip is unsupported during sex, my hip rotators tire out. And if I change position or put a pillow under my hips or jump onto all fours, then I feel better. So if we have that sort of presentation as a physio, we should be focusing on local treatments. So let's find your obturator internus. It's a muscle that's frequently intimate with intimacy. It sits right on that side of your vagina. So intimacy around having a tight obturator internus or pelvic floor, we do certain local things, but it doesn't mean if you've got this sort of mechanical pain, it doesn't mean that you've got issues in your tissues. So the way that we would manage that is we go, let's try one strategy and see how you go, and practice it a lot and see how you go. So it's sort of like what we would call a stepwise approach. Other thing that we might do, and Rochelle's talked about this, is keep as sexually active as you can, whether it's one to yourself or with some others. So we want to, if there is sexual problems, just to keep your heart as open as you can, keep everything that feels safe and intimate alive, reading to each other, eye gazing, lounging over each other, kissing, hugs, hand holding, oral, fingers, anything that feels safe, keep it going. And we have this concept in physio called non-neuroceptive interaction. So that means do something that feels good. But in a physio term, what we do is, it's like using a strength-based approach. What can you do? And let's build on that, and keeping everything feeling comfortable, building confidence, and building a sense that I have a bit of control because I can do this, that, and other. Keep as sexually active as you can on your own. Do everything that you can that feels good. And remember, remind yourself that it's not your tissues. You can't cause damage with intimacy. It's an overprotective reaction. And explore what feels safe. Stroke your belly, thigh, vulva. What we know from the great work of Lorimer Moseley and Noy is our brain can lose a clear perception of what our body is in space. A perfect example of that is women who've just had babies, how they just go, you might ask them to tilt their pelvis and they'll go, I know what you're asking me to do, and I've done that before, but I can't do this right now. And it's because their body image and the representation of their image of their body has changed so quickly. And so when we avoid touch and avoid doing things that are normal, we keep saying movement is important, it's because we want to maintain this normal, healthy connection in our whole body. A strategy that we work on is see what happens when you pull your skin in different directions, because you can get very sensitive skin. And so the idea of actually doing gentle movements around the front of your thigh or in the labia, around the buttock and sacrum, if I balloon towards the area that might feel uncomfortable, just that change as compared to if I pull it apart. So get to know how your body's reacting and also what you can do about it. And is there any predictability? And so it can be quite fearful, but remember, I'm saying do all the things that feel safe and make sure that you're moving towards that. And the other thing is creating a long list of what you can enjoy doing. Now, I wanted to show you these beautiful vibrators that they're making. I've always found that the vibrator is also can be too phallic for my liking. I think there's often an influence or a bias towards that's what you're going to want. And these things, they just look like little bedside ornaments that are completely able to be immersed in water and have all different settings. And it's great. It's really good to see that there are changes happening, that we need things for our own pleasure. And the trainers that you can see there on the right can be little bridging steps that if you've lost confidence, you can use something very small. That's one of those is 2.5 centimetres wide. If penetration is your goal, then you can be working towards that. And anything we talk about here is going to take time. And I have that up on my wall for my own benefit. Everything takes time. And this is what success looks like. And there's a fantastic guy I saw at one of the Explain Pain meetings whose name is Frank Keefe, and he is psychiatrist, a professor of pain neuroscience. And his main message was, whenever you're trying to make change, take stock, celebrate. Keep going, take stock, celebrate. And so I wanted those ideas that we're taking a stepwise approach. You're repeating whatever strategy you take on. But he said very clearly, if you want to change your brain, we need to take stock and really celebrate what you can do often. There it is. The little wins really make up the big win. And so say you've tried one strategy, then you might go, okay, reevaluate, because we don't want to overload with all these things you need to do. So you might decide, yep, I'm going to do self-touch for a while, or whatever it is that you've chosen. You're going to decide if you need another strategy. So these were the mechanical ones, and that was a bit out of order, apologies. But if someone has a tight hip rotator, we might get the spiky ball in there and roll around on it, and it can feel like that good, bad sensation that really softens up the muscle. And it's a hip rotator, so we do exercises like that. There's a piece of equipment called the TheraOne that's just designed exactly to actually be able to give yourself some internal massage. Don't use it that often because external things work quite well. The ONUT is what Rochelle mentioned. So if someone has deep pain and it's from penetration. This O-Nut is actually quite popular. We sell these, but you can get them online. It's about actually, if you're going for penetration and there is a penis, that you lube the penis up and pop these on, and it prevents deep penetration, which can be quite a relief. Lubricants have been covered. Rochelle did a great job there. If your pelvic floor is really tense, there's local and global strategies that you can use. And we need to create safety, make sure that you've got people around you that believe you and validate you, or if they're not, tell them how to. And getting support is a beautiful global strategy, and connection to others that can help and who understand, and psychology, the Endo Help. There's a couple of support groups that I've come across. That one is the pelvic pain one, and Inner Strength has just started an pelvic pain exercise group, a small group, and that's the idea is that it's supportive as well. But other things that are global strategies are your breathing, your grounding. Grounding is that, and most people know this now, is that you externally look around and what are the 5 things I can see? What are 5 things I can hear? What are 5 things I can touch, to bring yourself into the moment? Meditation, my favorite, Tai Chi, Qigong, exercise, sleep, and prayer. The idea of Qigong and Tai Chi I love because they're movement meditations, and movement meditations mean that if it feels too confronting to sit, because built into our fight flight is don't sit, you're meant to be running or fighting. Sometimes it doesn't feel safe to sit down and meditate. So the moving meditations can be fantastic. And then local strategies that we use, body scan, contracting, relaxing, and feedback. So it could be feedback from muscle on the pelvic floor, ultrasound, or we use have a little machine that externally that can tell you what your muscles are doing. And really importantly, normal bladder and bowel habits. And I'll talk a little bit about that in a moment. But what's normal is that when you sit on the toilet, you relax, go when you need to. With a bowel, it's aim for a type 3 or 4 stool, and don't strain on the toilet. And the time in loo can be an opportunity to ground and breathe, because emptying is very much in that rest and digest field. So calming often is a good idea. Plus you go there a lot. So then if there's less mechanical type of pain and it's more widespread, then we should take a different approach. And that's a lot more about counselling and lifestyle and education. So central pain, so if you were experiencing something that when you did something, it hurt, and it hurt in a larger area, and it was widespread, and the amount of, say, light touch causing pain means that there's a presence of disproportionate pain. And we talk about there being this central sensitization index. But if we find something like that, it's always going to be important to target the factors that keep the central nervous system in the alarm phase and aim at calming down your nervous system. And I've just mentioned them. It's education, stress management, sleep management, physical activity, exercise, and diet. And again, it doesn't mean there's issues in the tissues. So central sensitization is a score. And it's what they've found is there are many conditions where our body's in protective mode for a period of time, and then there are symptoms that become apparent after that. So you can see a list there. I won't go through it, but chronic pelvic and perineal pain are definitely on that list now. And you remember I talked about jaw. So where we protect ourselves is where the changes occur. Irritable bowel, migraine, tension type headache. Another guy, Wolf, talked about other ones that actually having period pain you put on that list as well, and chronic pelvic pain. Other things you can do if it's more of a central pain issue is that there's strong evidence for some medications, and sometimes you can be helped to know if it is a central thing, because some of these medications could be useful. I'm happy to share this talk if someone wants to go back over those. How do you manage if your nervous system is in protective mode, and it's been in protective mode for a while, and there are symptoms starting to develop, and you've got endometriosis? Anything that you do has to be targeted and individual, because everybody is different, and the treatment and your path is about finding what's part of your context and situation, and then working on what can I change. So I would suggest you pick one today. So you might go, all right, I want to know more about pain, because there's good evidence. And actually the evidence is if you find you're someone that is more feeling anxious about your pain, and feeling that you're thinking about your pain and checking in on your pain a lot, that actually education's probably the most useful. And with Joe Sheedy and I run a pelvic pain program, but just general information about pain and education about pain's on the Curable app, and that's actually quite good. And there's another one that's much more lay than some of the Noi or the Lorimer Moseley stuff. It's called My Cup of Joe. But stress management could be put on the top of your list if you choose to pick one. So meditation, yoga, Tai Chi, Qigong, prayer, breathing, sleep management, physical activity, exercise, therapy, and dietary improvement. And it might be that you already know a list of foods that make you feel bad, and you go, right, well, I'm just going to stop those for a while and not have them occasionally and see what happens. You can choose. Lots of options here. Now, my favorite is the walking, and this video is fantastic. It talks about if the doctor no longer had a prescription pad, what is the biggest difference they could make to your health? And it's walking half an hour a day. And you can power that up with connection by walking with a buddy. And so physios are really, if you see a physio, we're actually just the coach. And the walking and the stepping and the going up the stairs and taking one step at a time is actually something that's a personal journey. So I wish you well in that. And if there are any questions, I'm happy to answer them.
Thanks, Celia. Did anyone have any questions for Celia? Or any of the other speakers today?
I just would like some feedback if any of that was... Oh, that's a nice comment.
I was about to say, you got an amazing info, Celia. Bloody loved it.
That's so validating. Thank you. But yeah, look, it's very easy when you start talking about central pain to be left with that feeling of I am the problem. And I really, really don't think that is the case. Well, I think we've always got to keep remembering culture. We've got to keep remembering how women are treated right from when they're little, and how we get into situations of feeling unsafe for long periods of time. Honestly, yeah. I don't know about you, Meg, but that's what I walk away with every day.
Absolutely. Every day pain just becomes a more zoomed out phenomenon than the actual person in the chair, isn't it? It's such a pervasive cultural issue. And women and people with vaginas not feeling safe in the world is a huge part of the battle here, for sure. I loved it, Celia, too. Thanks so much. It was great to hear from you.
Yeah, it's really nice to hear what other people think and do. I've really enjoyed this. So yeah, please give us your comments, ask questions. I'd really love to hear what you think.
Can I just say, Celia, thanks for raising like the erogenous threat issue too. That's something I really noticed, especially postpartum trauma. not just endometrial, but postpartum trauma is a big thing with that. You know, and that preemptive pain, and some girls that have come along, I don't know why they think that I'm going to teach them how to put a tampon in, but some girls are sent into the sexual health clinic going, oh, you know, can you teach my daughter how to put a tampon in? It's like, seriously? And down the track, people that have come with issues about that preemptive, like that anxiety, preempting the fear, the pain, it has even come from being seemingly forced if they've been in swimming clubs and things as a young girl, and, you know, experiencing periods, and then being forced to use a tampon, and it just didn't go well. And then it's this preemptive, when I'm going to have any sexual intimacy, that pelvic floor becomes like a door, like a shut door. And I think that's really interesting, and that oxytocin releases, you know, the endorphin things, and helps with that biological understanding of that psychological roundabout we go through with that pelvic pain as well. So thank you for that. It's really worthwhile trying to understand that, I think, for people. Yeah.
Thanks.
I don't think we've got any questions. We've got lots of feedback saying that everybody's enjoyed it. So a big thank you to our speakers. If anyone does have a last minute question, please do either unmute yourself or put it in the questions. But otherwise, enjoy your Sunday, and thanks so much to our 3 speakers for volunteering their time on a Sunday to come and talk to us.
Thanks, Kat. Thanks for the opportunity.
Yeah, thanks, Kat. This is fantastic. Well done.
Appreciate you. Thanks, everyone.
Thanks. Bye.
See ya.
How was that, everybody?
I really enjoyed your talks, ladies.
It was
It
awesome.
was fantastic.
It was so fantastic that neither of us shared, like none of us shared our presentations, and yet they all seemed to just flow seamlessly and in a good order too. Because things that I missed, Celia, you picked up at the end, like all the grounding and practical thing. I thought it was fantastic. I really enjoyed it.
Yeah, thank you. Thanks.
I knew you ladies would get right into the nitty gritty. I was trying to be super practical because I thought, oh God, I'm going to be overwhelmed here as well by you ladies. It's like I was trying to be very practical.
Yes, you were practical as ever.
Yeah, that's great.
I don't know.
It's very hard to keep that language inclusive, isn't it, when you're talking practical?
Yes.
Yeah. And, you know, I think that's my issue with the clientele that I get. They're not well versed often in body parts. So I'm trying to keep it as you know, plain language. And because they're used to that medical talk, and then they get overwhelmed and they get a bit miffed with it, you know, and I'm thinking, okay, you've come for practical stuff, so try and just keep it as practical as possible. And sometimes I just think, God, am I talking to the kids down the street, basically? It's like, but, you know, and I don't want to insult anyone, trying to be very plain and simple. I don't know, but it's hard when you ladies in the areas you're coming from, you have to have that language to explain the depth of the issue, I think, which can be a bit hard for everyone, isn't it? Like, and trying to put it into a presentation, I think is really hard anyway. Yeah, I don't know. So hopefully the crowd were happy, Kat, overall.
I think so. I'm not sure. I'll find out whether I hear any more from the person that gave us the feedback. They left fairly early, so we'll see what they thought.
You're going to get feedback?
No, Sometimes I do and sometimes I don't. Sometimes I hear nothing. Sometimes I hear quite a bit.
Mm.
There's a bit of a war occurring in the endo space, so it'll depend on whether I get caught in the war or not.
Yeah, that's the thing. Like you said, Kat and Celia, it was just before you came along, the context, yeah, like it's a really hyper-activated time within the community. And then we're talking about something as close to home as sexual pain. Like, I'm not surprised that there was at least one person that was really activated. And I don't think that's personal to any of us. I just think that contextually the time is ripe for that. And like, we can absolutely try our best to use inclusive language, but like, we're all in our own bad habits and everything, and we're not perfect. So yeah, it's just
it's hard when you're trying to describe endometriosis. It only happens with a female body.
Yeah.
I mean, here I go again, making the same mistake as usual. But it's really hard. You're talking about a vagina. It doesn't matter who it's belonging to from a sexual identity, but it is female gendered anatomy that's sparking off the issue, and it is difficult I find it difficult, obviously, to behave in that language.
Yeah, it is. I find it hard. I really love having a 15-year-old daughter keeps picking me up.
perfect.
Yeah.
She's
the best
great.
training you can get, Celia.
Pardon?
That's the best training one could get. A 15-year-old
exactly.
calling mum out at every opportunity.
Yeah. Gosh.
I did feel a bit self-conscious because I was like, oh, I don't think, yeah. But anyway, we're only human and we're learning all the time. I think you're fine, Rochelle.
I think the other thing is we need to include everybody, but we can't disclude women.
No.
So, I've read websites about menstruation that don't mention the word women at all, and I kind of think we've worked so hard to bring women back into the space as far as data collection, empowerment, and if we just remove
only to make them invisible again. Yeah,
it's catch-22, isn't it?
Yeah. I had that exact conversation with a midwife friend who's there's moved to sort of say chest feeding.
Yeah.
Oh, I hate that. I know.
Yeah.
Oh my God. I had that conversation recently as well. And it's like, are you serious?
Yeah.
Like,
I don't know. I'm happy to be guided, but there's groups saying yes and groups saying no.
Yeah.
For that exact reason, Kat, we
It's
just became visible.
Well, I'm not saying don't. We've trying. I think we've got people with uteruses, but we're going to change it to women and people. So we've not.
Yeah, that's
not
great. I think,
women, but including everybody else. I don't know if that's the right thing, but that's, as a board, we had a robust discussion, and that's where we've landed.
Kat, I reckon from a trauma-informed perspective that I felt like I was taking up lots of time because I was almost labouring the point of trying to kind of name everyone. But I think your kind of choice there about, say, women and people with vulvas or whatever it might be, or uteruses, I think that's pretty robust.
I think we're going to just say and people, so that anybody can
I'd love the recording for that reason, because I'll go back and see what I would like to change. That'd be helpful.
Once the IT, I'll send it through to Jonathan, and once he's done whatever he does with it, because I don't know how to do it, I'll let you know, Celia.
Yeah, that's a great idea.
All right, well, enjoy your afternoon.
Thank you all. Much. We've got a lot more people that are going to watch the recording, so I know it was quiet today. I think that's partly because it's a nice sunny day, but there's plenty of people who've said I'm going to watch the recording. So
great. Thanks so much.
Thank you.
See ya. Bye.